Hi, everyone, and welcome to a live chat with Nurse Linda. Today's topic is New Beginnings. Linda Schultz is a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher and Dana Reeve Foundation for close to 2 decades. I'm now going to turn it over to Linda. Hi, Linda.
Well, thank you, Kaylee, and thank you everyone for joining today. It's a whole new year and it's kind of exciting, isn't it? I always think at the change of the calendar to a whole new year that there's something kind of special and magical about it. It's kind of an exciting time, really a time to think about new opportunities, what might happen. This new year could be very exciting. There's some word out on the news that the COVID is going down for this last spike. But please, please, please still continue to be cautious because there's so much we don't know about this virus and, which direction it's going to go, who knows. But anyway, things seem to be headed in the right direction for right now. Be sure and use your social distancing and mask wearing if you are able to wear a mask. People who shouldn't wear a mask are children under 2 and people who have significant respiratory problems, in which case then you have more of a burden to socially isolate. So, wash your hands thoroughly, wash your rims, just be extra cautious, try to keep people away from you as much as possible. I'm still doing all of those things. I've kind of gotten used to it now. I will be very, very happy to go back to not doing those things as religiously as I used to. Although I think some of these habits of, not getting so close to people, being in the breathing space in that regard, and washing our hands diligently is going to help our health tremendously with colds and flus and all kinds of things that we don't want to have anyway. So, we might be able to look back in some ways fondly. Trying to find a silver lining, although I know there isn't much. And certainly our thoughts go out to those people who have been affected, either that they've gotten the COVID and had some horrible times, or to those of our colleagues and friends that have been lost during this time. So, it's really been difficult, but hopefully we're seeing the light at the end of the tunnel, just way at the end of the tunnel. It makes me think of that old country song, "There's a light at the end of the tunnel. Oh, wait, it's a train coming," something like that. And sometimes it's like, oh yeah, it seems like the end is near. And then, especially with this COVID, things are going on. But anyway, this has been such a new year, and at the new year, it's always a time of change. And some people like to use the new year for resolutions, and they make commitments for the year. Those are really hard to keep, as we all know that oftentimes those are not well kept. But it's kind of this imaginary marker in time, because, time is a man-made created phenomenon. Creation of a year's time is a man-made. It's based on all kinds of things, but it's a man-made phenomenon. And so sometimes people like to do things at the new year. I like to do things on my birthday. So for my health concerns, anything that I have, like a yearly appointment or vaccinations or any kind of healthcare issues, I like to use my birthday, because then I give myself the gift of health for my birthday. And so that's kind of like my gift to me. And so I kind of take things that maybe I don't really want to have that colonoscopy, but it's the 10-year mark at my birthday. So, it's like, okay, I'll go do that because it's my gift to me. So imagine that kind of thinking. That's kind of wild thinking, but it works for me. So whatever works for you is good. So some of the things in talking about new beginnings this year, people are happy with their lives, and that is just great. But there's always room for improvement, no matter what. It's a new year. I got rid of my COVID hair. I was so excited. So that was something that was fun for me to do, because it was a new year and we had a little bit of lull there in December. And I thought, oh, okay, I'm going to go ahead and get this done while I can. Mask the whole time. It was a unique experience, but it felt good. So think about your life in this new year. Think about things maybe you want to change. Maybe things are going great, but there's something that maybe, you're thinking about, well, I'd like to make a change in that. And I know a lot of people want to make changes in their relationships. So they, want to look around and they want to think about, how they're interacting with people just in their general life. If you have a family members or care providers that are coming in to help you with things, think about your relationships with those people. And is there anything that's missing or something that you could maybe be doing better? Saying thank you more often, or getting to know them more as people instead of, like worker bees, or I don't know, just whatever kinds of things you do. Maybe you want to make some new relationships. And I know I am in that boat because I have friends that I see on the Zoom mostly, and I am really anxious to get back in person with my friends. And I was thinking, since I've been in the house and, cooped up all for a couple of years now, I was thinking maybe I'd like to expand my social circle and start looking for some new friends. So I've been thinking about ways to do that, still being in the house. Some people like I've known on the periphery that maybe I'd like to know better. Colleagues at work. I've gotten, surprisingly, I've gotten to know a lot of colleagues from work a lot better during this COVID time, because I would see them at conferences. And at first I was so disappointed because the conference would be canceled and I wouldn't be able to see them. And it's like you see each other once a year or maybe once every other year, but boom, you're like right on the same page. You have the same interests. We're at the conference because we're interested in whatever they're talking about. And so I was kind of really disappointed about that at first. But now, since we're not going to conference and doing things over Zoom, I'm actually interacting with them more than before, because, I'll Zoom with somebody or they'll Zoom me and say, I didn't see you at such and so. What do you think about this? We didn't get to talk about these new things that are coming out, or new policies, processes. So anyway, it's been a very, very interesting time. So, good and bad to everything, as always. So think about your relationships. I put some blog information in there about sexual relationships. If you have questions about that, there's a whole lot of new things on the horizon, especially for the males, as always, a little bit for the females, but that always kind of follows a little bit behind in the research. But there's some new things that are going on there that are making life more pleasant for people. There's some new devices on the market. If you're interested in pregnancy, there's some devices for males that you can collect sperm at home and not have to go to a clinic and have that done. Now, some people still will, but there's a whole bunch of new things that can make the experience more private, more intimate for you and your partner. So be sure and check that out, because that's going to be kind of interesting to see how all that goes. It's going now, and it's going real well. So we'll hope that carries on and people keep working on things like that. Also take time, sometime at least once a year, if not every month, to take a look at all the equipment that you're using. If you use a chair, if you use a walker, check all the little bits and pieces, check the armrests, those crack so easily. And if you get a little crack in one, you can tape it, or you can fill it like with Gorilla Glue. I am the queen of the Gorilla Glue, I have discovered. I love it. So you can do a little bitty repair on something maybe yourself before it turns into a whole big thing. If you let it go, those armrests continue to crack, and they get worse and worse and worse until you have to get a whole new piece and then take it all apart. And it's always more difficult when things get more complicated. So look at your brakes, look at all your elements. If you use a lift or any kind of piece of equipment. I know some people with walkers, sometimes they don't look at the gliders on them, or at the part of the walker that goes on the floor. Next thing you know, that's worn out, and the walker's scratching the floor. So if you want to preserve your home and your carpets and your flooring, be sure and look at those periodically, because they're down underneath the walker, so you don't really see those. So you really need to have a good look at those and what's going on. And then the other thing too is to look at your body and look at your processes. So if you do a bowel program, go back to your rehab discharge book, or go to the Christopher and Dana Reeve paralysis foundation site and look for bowel management process, look for bladder programming, so that you look at everything, every one of the steps, because like all humans, we tend to consolidate steps. We're always in a rush and we're hurrying. And so we tend to shorten things. And you may find out that there's a step you're missing that might make a huge difference in the general health of your life. So be sure and, do that periodically and look at those kind of things. Also, when you're checking your body, check your skin. People give that up relatively quickly. And that's something you really don't want to do. We lull ourselves into the idea that if you have a cushion that you're sitting on, that you're protected. There's no cushion. There's nothing that will eliminate pressure from your body. So you always have to check your skin and look for a little spot, which you can heal up much more easily and quicker than if it gets out of control too quickly and too fast. Be sure and look yourself, even if you have somebody who's helping you and they're checking your skin. Get a mirror and be sure and look at yourself, because they might not be there the next day, or they might get the COVID or get a cold or something, might not be able to come. You won't know how that it's your body. So you take ownership of that and be sure and do those things. Think about your mental health. Think about, oh my goodness, just ask yourself, am I happy? Well, I'll tell you, for me, I'm happy. I'm a basically more happy than not kind of person. Other people are more maybe even keel. Everybody has good days and bad days, good moments and bad moments. Some things stick with us a little bit longer than others. But think about your own mental well-being and think about if you're truly happy and what things you can do. Now, if you have a health condition, you might not be able to change that, but are there things you can do to make your life more adaptable? Such as, can you rearrange your household to make it more convenient? Or, just what kinds of things can you do, kind of reduce some of the annoyances in your life? We all have annoyances. I have to take my car to get it fixed. That's an annoyance. It's not comparable, but there are things like when the computer doesn't work. Oh, that really annoys me. So, look at all those kinds of things and think about what kinds of things. I had my son-in-law do a tune-up on my computer over Christmas, which was fabulous. He's got it, just a dynamic system set up for me. I'm really thrilled with it. But then, of course, after he left, everything had to be rebooted and returned on. I'm like, this is taking so long. I have to redo all this stuff. It was fine because in the bigger picture, it was much, much better. But, it's those little things you don't plan for that kind of like eat away at you. So think about those things. But I'm going to move quickly today into the questions because there are so many really fantastic questions. And so I'm just going to run down the list because I want to be able to get to all of them as best that I can. So the first question is from somebody, and I am assuming that maybe this person is a rehabilitation specialist in some sort of way, but maybe they're just asking out of general interest. And that's the role of OT and bowel and bladder care in the acute care setting. So the tide has kind of turned in that services that are offered like physical therapy and occupational therapy, because they bill by the hour, some of the care items, the education that nursing used to take care of has been moved into these other areas. And part of the reason for that is because they can bill by the hour, so they bill by the session. Now, nursing used to take care of all the bowel and bladder skin issues, but because they are built into the hospital fee, they don't get special pay for that. That just goes in their daily pay. And so it's much more beneficial to have the pay system go that way. Now, this is probably being very too politically to say all these things, but that seems to me to be the way that this has processed. It makes sense because it's always been a team approach. It's never just one person. It's never just a nurse that's teaching this. Everybody has to be on the same page. the therapist might teach somebody how to transfer. The physical therapist, the occupational therapist might be getting a special adaptive equipment to enhance hand function or something. So everybody's always had a piece of the pie, but now it's going into the world where either the PT or OT is actually giving the education, and then the follow through comes through with a nurse in the regular daily care. So as we know, bowel programs and don't usually go on a time schedule. And once you learn how to do bladder catheterization or management of however you're managing your bladder, once you learn how to do that, then the nurse can monitor and help you as needed. So that seems to be the way that the tide has turned a bit in that direction. So PT and OT are taking over more of the education part of that. Now, you won't find that in all facilities. Some people still do it in the traditional way with nursing being in charge of that, but that seems to be the way. If, if somebody can get paid for specific time to do that, it's just kind of the way that the tide has turned about that. It's a good thing. It was good when nursing did it. It's good when other people do it. I think one of the biggest differences is that when you're working with your occupational therapist or your physical therapist, they're focused on the physical therapy needs and the occupational therapy needs. The nurse has to focus on all those things and the nursing needs. The one downside that I see that I would hope that people will do is that oftentimes when somebody else besides the nurse, and I'm a nurse, so, I bias in that way, I admit that freely, but it's not like it's a secret formula that only one discipline has. It's pretty standard. And you do it when you're at home by yourself. So, it's not like it's like the secret key to the kingdom or something. But the one thing that I do see is that often the PT and the OT don't really know what medications the patients are on. And, the OT will come and say, this person had this huge bowel movement, and they'll come tell me about this. And I'll be like, well, yes, because they take Metamucil and that makes for a larger bowel movement. Oh, well, that makes a lot of sense then. Yeah. So I hope that they are able to gain access to the medications as well, so they can kind of see or discuss with the nurse, the stool quality. I always advise using the Bristol scale because that gives a language for everybody to describe the stool. It's embarrassing for some patients to describe their stool to the healthcare provider. And so if you use that Bristol scale, and you can just look up Bristol scale, Google it, and there's pictures of what the stool should look like, what is considered normal stool when you're constipated, when you're diarrhea. So, and then they compare it to different kinds of soups, or they'll compare it to different candy bars. It's really kind of macabre in many ways, but it's very helpful because it something more familiar to you. Oh, my stool looks like a Baby Ruth. I need to have a little something more fiber or something with that. So the Bristol scale is very, very helpful. It's BRISTOL. So it's spelled a little different. It's from Bristol, England, and that's why it's called that. So the next question is, what's the best way to remove bursitis on the hip for quadriplegic? Okay, so this is really a two-parter question for me. So to remove the bursitis, sometimes you can take things as simple as anti-inflammatory medications. Those are over-the-counter medications. There are prescription medications that can help with bursitis and those kinds of things. Sometimes, depending on the bursitis, a very small amount of movement to that joint will help. I'm not recommending that outright. You need to have that checked because it can also hurt. So sometimes a little bit of movement, as with arthritis, some gentle movement will help ease some of that pain. But if you want to remove that bursitis, you would either have to take some medications or maybe have surgery if the bursitis is so bad that you would need to have surgery in that particular joint. So that is something you need to check with your healthcare provider. The thing that the question about bursitis makes me think of another thing that happens. This person says they're quadriplegic. It makes me think of another condition that people with paralysis quadriplegia, even paraplegia sometimes get, and it's something called heterotrophic, ossification. So it's called HO for short. So if you talk to your healthcare professional about HO, it's heterotrophic ossification. And what that is that the bone sometimes loses track of where the bone's supposed to grow. And so what will happen is the bone, bone, like the rest of the body, it's turning over its cells, it's replenishing itself, just like the skin, all the parts of our bodies do that. And so sometimes the bone loses track of where it's supposed to be turning over new bone. So where those new bone cells are being grown and then implanted in the bone. And so sometimes it loses track and bone grows into the muscle, and that can be confused with bursitis. So with this bursitis, as a quadriplegic, should really have that checked, because it can be heterotrophic ossification, for which there's a medication that you can take. If it gets so bad that the bone is so grown into the muscle, if you don't tend to it and get it cared for with a simpler treatment, then sometimes you have to go in and you have to take out the bone, which is entwined in the muscle, and then that affects the muscle, and it gets into a whole big deal. So be sure and check, is it bursitis or is it HO? So I put that out there for everyone to think about. If you have any problems with your joints, if you feel like a nodule around a joint, or you feel a hard bump or something around your joints, be sure and check. It could be arthritis, it could be bursitis, it could be HO, could have a fracture, you could have a healed fracture. Any of these things could be. So you really want to differentiate, because some things you would treat and some things you wouldn't treat. And you would treat all of those things differently. Now, the next question is about, are the prices on stationary bikes with FES coming down? And I'm happy to report, why, yes, it is. And it's coming down quite dramatically. And why is that? It's the old American way of competition. And so new companies are coming out with bikes, FES bikes that they have developed. You can get special apparatus if you want hand cranks as well as feet cranks. There's a lot of positive outcomes from the FES bikes. Of course, not everyone can do them. You have to have a higher level injury. If you have a lower level injury, your nerves and muscles are not going to stimulate, in which case you do passive biking with a bike that automatically goes, but without the electrical feature. So there are many alternatives for that. And if you look up FES bicycles, again, on the computer, you're going to find a wide array, because it is so profitable that companies are doing this. Now, they're very difficult to get through a payer system because they are so expensive. But as we see the prices coming down, and I've seen some for $15,000, there's a company that I had heard them talking before the COVID, so I'm not sure where this stands now, because you miss a lot on that. With that COVID, without going to some of these conferences, you miss a lot of new things that are going on. But there was a company that was working on one for $10,000. Now, they're not as bells and whistles and fancy as the more expensive bikes, but they do the same job. So, if you're really wanting that, you can talk to your healthcare provider about one of these less expensive ones. They appear to do the same work as the more expensive bikes. Some people will find them online for resale. Buyer beware. Some of them are being sold maybe because they're not working correctly. By and large, I find that most people, they were using the bike, they've gone on to different things in their life, and they just don't want that big piece of equipment anymore. So sometimes you can find a very good piece of equipment for resale. But there again, I say, has it been overused and maybe it's not working up to efficiency? You have to, it's like buying a used car. You have to check it all out very completely. This next person has a very interesting question. And they were injured in 1985, they're C5-6. And they're a young person, 36 years old, and they have 3 of those wound vacs on pressure injuries on the bottom. And so 3 wound vacs. So they've got several different locations of injury would be my assumption. And now they're saying that it gets hot. I'm saying he, it might be a she. I'll just say they get hot when they turn and have more spasms when they're turning that. And so their question is AD kicking in? Well, now here's a couple of answers to your question. So why are you getting hot now when you weren't getting hot before with the 3 vacs? And I would think that maybe it is because you're having some healing to those wounds. So there's a lot of metabolism going on in there. Maybe the suction on the wounds, which those vacuum suctions, they keep the debris out of the wound to keep it clean, which is a good thing. They're lovely to have on some of these really deep wounds, especially because they keep them clean. And you want those wounds to heal from the bottom up. So you want it to heal from inside the body. You don't want the skin to close over the top, because that can leave infection in the wound, or it's not healed in the wound, and an abscess can occur. So you want to leave the skin to be the last layer to be closed. And so it could be that you're getting hot and more spasms because there's so much healing going on in that particular area that maybe your body couldn't sense or feel when the wound had maybe a lot more decay and debris in it, but the vac has taken that out. And so you're getting more response from your body now that it's been cleaned up a little bit. So that is one answer. Now, the second, and that can result in spasms as well. The second part of the question is AD just kicking in. And I did want to talk about that a little bit, because this person was injured in 1985. And a lot of people think if you get AD, that you get it as soon as spinal cord shock goes away, and then you have it. And some people get it, some people don't get it. Why? Nobody knows. But that seems to be, there's no predictor of who's going to get it. People with a higher level injuries get it. Way back when we used to say at T4, then they dropped it down to T6. Now it's dropped down to T10. Anybody with spinal cord injury from really T10 and above. T6 is the classical level now, but people as low as T10 get it. People get it without any symptoms except the blood pressure increase. So there's also silent AD. So you need to be checking your blood pressure with different activities to make sure you're not experiencing silent AD, because it does have effect on the cardiovascular system. So if you're having that, you want to be able to get treatment for that. So now, is AD just kicking in since 1985? That is possible. Shockingly, it's possible. Some people get AD as soon as that spinal shock goes away. Sometimes it's 6 months later, sometimes it's a year or two later. But sometimes people don't get it until much, much later. Is it coming from these wounds, or is it coming from something else? Well, in AD, we always look for the top 3 sources of AD stimulation, something that stimulates an AD occurrence. Number 1 is bladder problems. So maybe you have these wounds, but maybe you're feeling warm, and maybe you're having spasms. Maybe you have a bladder infection and don't know it, or there's a kink in the catheter, or something's going on with the drainage. Second is the second inciter of AD is bowel. So make sure you're on a good bowel program, and that's working efficiently and effectively, because with these wounds, something could be going on with your bowel as well. The wound could crater off into the bowel, and there could be a connection there or something. So that could be a problem. Make sure your wounds are healing the way they're supposed to be healing. There's no tunneling or erosion going in underneath the wound where you can't see. And then the third area that's a third inciter of AD is skin. So, you're right on target with thinking about, could it be something about these wounds? And as much as the start of a wound can create an AD episode, so can healing of a wound create an AD episode. So if you're not having, you don't mention anything about the blood pressure. So that is the definitive. If you have increased blood pressure. And so that's not mentioned here, but is AD kicking in? Could be, but probably it's something else to do with the wounds, unless you're having that blood pressure issue. The next one is a question about a situation that really needs some attention. And it's a parent and caregiver of a person who has a son who's a C5, C6 quadriplegic, and he's a 30-year-old person. So again, another young person. He's in constant pain. He's basically bed-bound, depressed, and has lost all hope. Well, yeah, I would be too. I think we all would be. So she's trying to figure out how to build him up and encourage him emotionally or help him physically. Well, first of all, anybody who has constant pain is going to be miserable. That is something that just grates on your whole body, your mental health. I mean, you know, it's just a horrible, horrible situation to be in. So the very first thing to do is talk to the healthcare professional about getting that pain under control. And it usually starts out with a hierarchy, the lowest level of care, and moving up to the higher level of care. So it usually starts out with doing some very gentle range of motion. And people say, oh no, I hurt, I don't want to move. Think about people who have arthritis. I have arthritis, I don't want to move. It hurts when I move. But if you move very gently, just very gently and very calmly, it really loosens up the muscles and the joints and gets the blood flowing. And it really helps a lot with pain. Since this pain is constant and so ongoing, you probably are going to need something much more. Now, some pain is muscular pain, and it can be treated with Tylenol and again, those non-inflammatories, ibuprofen, Aleve, all those kind of drugs. So muscular pain works that way. In individuals with spinal cord injury, they usually have neuropathic pain, which is pain from nerves. And medications for that are anti-seizure medications or antidepressant medications, but given in smaller amounts. Now, people who have depression and take medication for depression, which is given in larger amounts, tend to have less pain because they're on medication that helps control the neuropathic pain. So you see, it's kind of a 2-for-1 kind of thing on that. So that would be the next level. But there's also 2 medications, gabapentin and pregabalin, Neurontin and Lyrica, that are manufactured specifically for nerve pain troubles. So you need to get with your doctor, get the pain under control. When the pain gets under control, one of the things that's going to be helping is to sit up in the wheelchair, can't get around too much. It's cold weather, this huge snowstorms coming to the east, so I hear. So you can't really get outside too much, but if you could at least move to a different room of the house. If he's in bed, if you can move his bed to a different room of the house in the day and have his day bed, his day place where his bed is in the daytime and place in the for sleeping. That you can't move a hospital bed in and out through a regular door frame. So, that might be an impossibility, but if there's any way of doing that kind of thing. So it sounds like you need some rehabilitation. It sounds like things are not going well. Please call your healthcare professional, because there needs to be some intervention here. There needs to be some control for this pain, and there needs to be some therapy so he can get out of bed, so he can do things, so he can live a life. If you don't have a place to go where you are, you don't have a doctor, be sure and call the professionals at the Christopher and Dana Reeve, the Educate Paralysis Foundation, the support specialists. They can help you find a place close to your home. Pardon me, I need to take a little drink. I don't like drinking in the middle, but sometimes you just have to. It's better than hacking around. So be sure and talk to it. There's also the peer support group. There's in the chat, there's the link to this peer support and mentors. There might be somebody in the area who he would be able to relate to, somebody maybe about his age, maybe somebody who's had a spinal cord injury for a while, who can make it talk about things, just how to get around, what to do, how to access this, or how to go to the movies when it's safe to go to the movies, how to do things in your own community, where to go to the dentist, all those kinds of things. So you need to do more than, of course, you're talking to him is going to help. Your help is going to be invaluable to him, but you need to do something more to kind of break the cycle here of what's going on. So be sure and contact any of these resources, but talk to your healthcare professional, because that's going to be a critical piece to get things in order, to get things in control, to get the systems that he needs in place to help him. The next question is what to do when Botox does not work for intense bladder spasms. Can increase movement, specifically use of a standing frame bikes or bikes stims, bring a neurogenic bladder back? And please touch on the implications of bladder removal. So Botox is the treatment for spasms right now. It's wonderful. There are oral medications that you can take, but then it affects your whole body. So some people don't like the oral medications because they say it gives them brain fog, and they feel kind of limp because their whole body is relaxed. That when you take a Tylenol, it works on your whole body. It doesn't work on that headache right here, just there in that one spot. It works in your whole body when you take it through your mouth, and it goes through your whole system. So injections are very helpful because they work just at the point of where the spasms are occurring. Sometimes if that is not working, sometimes maybe you need a little more Botox in that particular area. If the person delivering the Botox says, I've given all that I can give, you might want to ask for a second opinion. Another thing that you can do is sometimes people need so much Botox that they will get an implant that is put in the abdomen, and a little tube runs around, and the Botox is delivered into the spinal column. So not into the spinal cord, but into the column where the spinal cord is. And the Botox bathes the lower half of the spinal cord, reducing all the spasms in the lower part of the body. And so sometimes people need more Botox than can be given in the traditional ways. So sometimes that is an option that can be done. Would movement help? Well, I'm a big believer in movement. Would it help for the bladder spasms? I'm not quite sure if it would or if it wouldn't. But, it would be worth a try. It's certainly, movement can certainly shake up the bladder. So the bacteria, if you have an infection, you get a bacteria, it shakes up the bladder because you're moving your body instead of your bladder just being still, so that the bacteria cannot glom onto the bladder wall. And so it helps that kind of thing. Stretching your legs, would that then affect, one muscle affects another muscle. They all work interactively. So if you were in a standing frame and stretching your legs, putting weight through the body, I've not heard of that affecting the bladder directly, but it makes sense that it might with a combination of the Botox, it just might. Doing the stimulation, the bikes with the FES, that might also help your bladder spasms because, again, of the interaction of all the muscles working together. It could possibly be. There are some FES devices that can be placed on the abdomen that might help, not with the bike, just some FES, electrical stim, placed over the area of the bladder or on the back lower spine on the skin. Sometimes that will help with bladder spasms. That's often overlooked with bladder spasms because Botox is so easy to do. So that might be another thing. So do the bikes and standing frames bring a neurogenic bladder back? There have been improvements with FES and neurogenic bladders. Especially with the new implanted FES that's going on. This FES is just taking off right now. Functional electrical stimulation can be done with electrodes put on the outside of the skin, or there are implants that are being studied. For bowel and bladder, there are implants that can be done because the bowel and bladder nerves come out of the spine at the very base of the spine, and those where the central nerves from the spinal cord come out of the spinal cord in the cauda equina, those are peripheral nerves, and those can have electrodes put on there. And so there are devices that can be implanted that can control those. And so by the press of a button, or by pressing something on your phone, a button on your phone, your sphincters can open and urine can be released, and then your sphincter closes, and can be done for bowel control as well as for male sexual function. So there's a lot on the table with that, a lot to explore. So we'll bring it back. Well, ultimately that is the hope. Some of the FES that's being done in different projects around, they're finding that when the FES is turned on, like when they're on the bike, patients moving their legs, pedaling the bike, but when the FES is turned off, there's a little bit of carryover, and that's still working. So would it bring back a neurogenic bladder? Well, that we have to wait and see, but we know that it does have some positive effects. Now, the implications of bladder removal is then you would have an ileostomy. So you would have an opening from either the end of the ureter, or maybe sometimes they do different kinds of surgeries, but there's an opening from the inside of the body to the outside of the body. And then you have to wear a little bag to collect the urine. Some people will have a pouch inside their body. So that's, there are all kinds of options if that is done. That's kind of a last resort kind of thing. So I think you have a lot more to investigate before you get to that point. Let's see, there was something else that slipped through my mind about that. Also, if you're having a problem, be sure and have urodynamic studies done if you haven't already, because that's going to help see what's going on. Sometimes the bladder is trying to contract with a spasm, and at the same time, the urethra is closing. And if these are both closing and that bladder is contracting and the urethra is closed so the urine can't get out, you can have trouble of urine going back up into the ureters, or you can have this huge cramp, just this huge cramp. It's called detrusor sphincter dyssynergia, DSD. And so that's a different treatment altogether. So be sure to have the urodynamics to see if what you're being treated for with the Botox is what you need treatment for. So sometimes people need treatment, Botox in the urethra, sometimes in the bladder, sometimes in both. Be sure and have a complete urological workup done by somebody who is familiar with spinal cord injury. And so that would be a good place to go for that. How far are we in for a solution to cure paralysis? Well, I will say very close. However, if you're on the side of paralysis, if you have paralysis, why didn't it happen 20 years ago? One day is a day too many. So we're actually very close. The progress being made right now is just by leaps and bounds with all the FES stimulation, with stem cell treatment that's going on. They were having trouble with implanting it into the injury, the spinal cord injury itself. And they've got that mastered. They've got scaffolding in to hold the stem cells in place. So they're doing a lot of things. Now, in the first week of February, I have a blog about some interesting things that are going on in science right now that have nothing to do with spinal cord injury, but it has everything to do with spinal cord injury. So I'm sure you've probably heard about, it's been on the news about, you can transplant organs from other animals. You can transplant organs from other people, but there's all compatibility issues. And then you have rejection factors and you have to take anti-rejection medicine. But what they have found is that they have re-engineered genetically pigs, and they're in the laboratory. They've taken two pig kidneys that we've heard about. They've done the pig kidney transplant, well, actually 3 times. So they did 2 pig kidney transplants with these genetically re-engineered pig kidneys. The first two were in people who donated their living bodies. So they were brain individuals who suffered brain death. And they were allowed to transplant the pig kidney, but only for 3 days, because you know, you have to respect for the dead as well. And so they left the pig kidney outside the body, but they hooked it up to the ureters, and anyway, they hooked it all up to the arteries, and within minutes, the pig kidney was making urine, and at 3 days there was no sign of rejection. They left the kidney outside the body so they could see exactly when if rejection started, and within those 3 days it did not. And so that's been very interesting to follow that. The third person that they did, they actually implanted the kidney inside the person, again, for the 3 days. These are called proof of concept studies. So it's taking stuff from the laboratory and trying it into human with no expectation that they will recover. It's just to see if does this work? Does this not work? What's going to come out? It's called proof of concept. Another thing that they did was they genetically re-engineered a pig heart, and they transplanted it into a person. Now, why all of these are important is because this is the first time that these big solid organs have been successfully transplanted that didn't immediately reject and, you know, kill the person. So these are huge, huge leaps in studies. What it means for people with paralysis is yet to be seen, because transplanting a spinal cord would be a lot different. You know, there's a lot of connections there with all those nerves. And so, but anyway, it's this proof of concept, because if you could do that, you could also maybe transplant some factor to re-engineer the spinal cord deficit. So this is really talking way out in the future. But anyway, it's really big stuff that's going on. There's also some vaccines that's going on. There's a question later on, and I'll talk about it now because it will make more sense if I do. And it's about a company that is, they're developing a product that when the body tries to heal itself, there are certain factors that keep everything in control in the body. So if you get a cut on your finger, you want that cut to heal, but you don't want it to heal so much that you have a great big scar there. You don't want it to keep healing after it's healed. So there are some protection mechanisms for making that happen, and that happens in the spinal cord as well. The nervous system is trying to heal, and there's trouble because you know, the body says, no, wait, you're trying to heal too much, because it just is looking at the facts. It's not, you know, and you're like, no, I need this to heal right now. But this other person wrote in about this NervGen Pharma Corporation. And the research scientist that's doing it is from Ohio. And he's very well known and you know, all above board. He's really doing a lot of great things. So, you know, will it be an IV drug that will help? Will it be these implanted FES devices? Will that help? Probably. Will it be something with stem cells? Maybe. Will it be something with injections or transplants or genetic engineering to keep people from rejecting their own body from healing, or from their own cells from dying from apoptosis, and all these kinds of things. So yes, there's a lot going on, and they're finding out more and more and more and more things all the time. So yes, it's a great time. Is it far off? Well, of course, nobody knows really the answer to that question. So we're going to be hopeful and keep these scientists working. So there's a question on the chat about a person who had a bone density test, and their doctor put them on a new drug, C567, incomplete, for 25 years. She started to stand up in the standing frame. Do you think standing will improve your bone health? Well, there's some evidence that it does, because you're putting weight through those long bones. There's also some studies that have been done that said, well, it really doesn't do that much, but because you're putting weight through those long bones, it's a good thing. And that that is helpful. You have to have bones strong enough to be able to put weight through them. So it's a good thing that you have had the bone density test to make sure that you're safe to do that. You don't want to put weight after 25 years on your bones if they're not dense enough to hold up your body weight. So those kind of things. Those kind of things are important to have done. There's also a question, do you know what would cause low pressure when intermittent catheterization? So I'm not quite sure of what would be causing what you're terming low pressure. If you are catheterizing, again, I apologize. If you're catheterizing laying down, there's not going to be that force of urine. Urine comes out of your bladder because the bladder contracts. If you have a spinal cord injury, your bladder might not be contracting as quickly. You might not have a rapid stream. If you're laying down, if you're on the toilet, this is your bladder, and this is your urethra. If you're on the toilet, your bladder is open at the bottom and gravity is going to pull the urine down. If you're on the toilet, also helps with stool removal. A lot of times, because rehabs are so, inpatient stays are so short, people learn to do this in the bed and they go home and they never do it sitting up, taking advantage of our friend gravity, which is really helpful. So if you're laying down doing your intermittent catheterization, your bladder is, your urethra's here, the urine's going to be pooling down here instead of here. So your catheter goes into the bladder and all the urine is down here. And then you've got to work to get that urine out. Whereas if you're sitting, urine pulls down here. And so that's the important thing, is to sitting. So that's what I'm thinking about, why you might be having some trouble getting that urine out of there. So what can be done to help osteoporosis when you're paralyzed? Again, standing frame is being used. If you're able to get any biking in, FES or non-biking, because even if you just move your legs with stretching your arms and legs and any parts of your body that's paralyzed, when you're moving, those tendons that are attach your muscle to the bones, they're being pulled, and that strengthens your muscle. So the more you move, the more your tendons are pulling against the muscle and the bone, and that makes your bones stronger. So very important thing to check. So those are the good things. If you can just move your body or have someone move it for you a couple of times a day, 10 rotations at a time, it's a start. A standing frame is pretty much allowed by almost all insurance carriers, even the Medicaids in most states. So be sure and have your healthcare provider order one, and you can learn how to use that standing frame. You need to go through a healthcare provider. Again, you need to check and make sure your body's able to do this therapy before you just start doing these therapies. And then if you can get anything in the more advanced therapies, partial weight supported walking, the FES bikes, even if you have an FES stimulator just to stimulate those muscles and nerves in your legs, those are going to be able to help. Oh, and here's a question that's really an interesting one. As a person who has cold extremities, so her son is Asia D, and so he has quadriplegia and quite a bit of sensation in his lower extremities. He started quad skiing and his foot turned blue due to the cold. The color returned when he removed his boot and warmed his feet inside. I suggested warmers, but he thinks it's overkill. So, okay, so you're out in the cold, you're having a great time. What do? We spend a little more time than we should, and probably didn't go in and check and make sure that his feet were okay. So sometimes those feet warmers will overheat, and if you don't have sensation, you won't know that your foot is burning. Since he didn't know his foot was turning blue, even though he has sensation, if you get that cold, your foot's turning blue, the blood's constricting, that kind of sort of hurts. So he probably didn't notice it because he was just having the time of his life, and good for him. But you might want to check to make sure the boots weren't too tight, that it wasn't, maybe one of them wasn't constricting his foot, cutting off the blood supply. You might want to avoid the foot warmers, because those, even the kinds that you break open the package and you put them in your glove or you put them in your shoe, sometimes those can cause burns. So that you might want to not want to do that. You might want to get a bigger boot if you're running, and put on a couple of pairs of woolen socks, maybe a sock that conforms, because wool sometimes, bunches up. Wool and cotton, natural fibers, sometimes bunch up. That's why socks have a little bit of elasticity to them, so they don't bunch up under your feet and make a pressure injury. So I would think the foot warmers, might cause a burn. If you didn't feel that foot turning, the blood circulation, if that didn't cause enough pain, he might not feel the pain of that. But to, be sure and bundle up his feet, take some breaks, look at his foot and both feet until he becomes maybe a more adept into noticing what those different feelings are, and that kind of situation. Let's do one more question. Somebody is looking for a rehabilitation psychologist. They're looking for a directory of rehabilitation psychologists in Virginia. And where do I find one? Well, you can check, you can call the, what are they called? There's a psychologists are licensed. So check with your state board. They'll direct you either to the place, or they'll be holding the licensure. People usually put their specialty in there. So like some people are marriage counseling, psychologists, some people treat depression, some people, all different kinds of things. So somebody will have themselves listed as a rehabilitation psychology. Some universities have rehabilitation psychology programs. So if there's universities around, you can look online, look up rehabilitation psychologist in Virginia. And Google that and see what comes up. So there's a variety of ways that you can find that. And then they're also looking for an occupational therapist or someone who will come to their house to help them figure out how to arrange and store things for people who are using wheelchairs. Now, there are people who that you can hire to do that. And they're interior designers that have specialty. Architecture people sometimes have specialty in design for different type of ability levels. There are some schools, if they have an OT program, you can contact that. Some schools have classes in this, and they are looking for people where they want to send students out to your home, and they'll create as a design and help you with organizations in either the design or the occupational therapy department. And so you can get that service, have the students come with, no charge to you, and you're helping somebody learn something new, because you can kind of work together. They come back and say, how did this work out for you? Well, gee, this worked out okay, but that didn't work out so much. So it's really a give and take with no matter who you have coming in there. But there's a lot of different ways that you can organize your house. And there's a lot of different people that would be willing to do that. And you might even be able to, as I say, you might be able to find somebody for free. If there's an occupational therapy department where you get your rehab, they do home visits and they help with that sort of thing. So you can have your doctor order a home visit to help with that, and your medical payer might pay for that particular visit, or 2 or 3 or 4. If you're an inpatient at a rehab facility, they used to do a lot of that. Now they do it more by video. Somebody takes a video of your home, and then they'll review the video and make suggestions for how to reorganize your home. So there's all kinds of things, from reorganizing the kitchen to, making architectural changes. So that's, really what you would like to have. So that's kind of a fun note to end on. I do want to point out, though, thank you, first of all, for coming today. We've had some really great questions, and we'll continue to answer these through the next few sessions as well. We do have a new program that's starting. The first one's going to be on February 9th. So it's coming up. It's at 2 p.m. Central. So that would be 1 p.m. Eastern. And then, you know, wherever you are. And it's going to be a webinar interviewing professionals that are kind of the movers and shakers in the paralysis world. People who've been working a long time at this have made some discoveries, very interesting people, very well accomplished individuals. And so this first one on February 9th is going to be a really exciting one. It's great for the kickoff. It's with David R. Gator Jr., who's an MD, PhD, MS. He is the professor and chair of physical medicine at the University of Miami. Sorry for that. And he's the chief medical officer of the Christine E. Lynn Rehabilitation Center for the Miami Project to Cure Paralysis. He's also the co-director of the NIDILRR South Florida Spinal Cord Injury Model System. And he is also this year the president of the Academy of Spinal Cord Injury Professionals. So quite an accomplished individual. And he's going to be on with me February 9th at 2 p.m. Central. And he'll be talking about energy metabolism. So he's done all this work in energy metabolism and spinal cord injury. You'll see on the chat box, there is a sign up. Be sure and look for the announcements if you missed the sign up on the chat box today. But be sure and check into this, because this is going to be really great. If you're a healthcare professional, you really want to tune into this new series. They also will be recorded so that you can listen to them later if you can't come at that exact time. But they're really going to be some exciting things with people on the forefront, cutting edge, to find out what they're doing and how we can do that in our daily practice. So there's one more person that has a question. It's past time, but I just saw it come up, Brian. I'm so sorry. He's asked his doctor why he has pains in his leg and his buttocks when he is at a T5 complete. He has no sensation with his lesion. You know, pain is a double-edged sword. When you have some pain like this, it's a miscommunication by the nerve. And so that is uncomfortable and that's bad. And again, you might want to try the Neurontin or the Lyrica or some of the other medications that can help with that nerve pain. The reason why pain is good is that some message is getting through. So something is working. It's not working correctly because you have pain, but something is working. So we always consider that a good thing. Sometimes when I have patients in when I'm seeing patients and they have pain, we try to capitalize that and get them into some rehab to see if there's anything we can do to harness that nerve to get it to transmit the way they want it, or to change a person's actions to get that nerve to work the way they want it. But you can get that pain control. And that's what it is. It's something, is some nerve in there has found a little route through, and those nerves are connecting in some way, but the signal's coming through as pain, which is unfortunate, but a signal's coming through, which is fortunate. So that's a good thing. So again, I thank you very much for coming today. I'll see you next month if I don't see you on February 9th. Thanks so much. Bye.